Okay, so, but how do I know the difference? If they're not better, do I treat or do I not treat? And Dr. Ampel has already kind of gone over this. The IDSA guidelines do have qualities. If your patient meets any of these, you might say, okay, this is someone that probably needs some treatment. We did a look back study that is not yet published, and it was just, who did we treat, who did we not treat? Mayo patients, and so it is what it is. 322 were reviewed, and 190 were treated, and those were hospitalized, diabetic, immunocompromised, etc. But I'm focusing on the 113 who didn't get treatment, and 88% of them did very, very well. So again, I'm going to reemphasize Dr. Ampel's point is we don't actually have to treat every case of cocci. Now, 2 of them had a poor outcome. Was it recognized as cocci fast enough? They were already immunocompromised and did poorly. And 7% had relapsed cocci, and those were people, again, who did have risk factors for having a problem. They were either had diabetes mellitus or, again, were immunosuppressed in some way, shape, or form. But if you look at the vast majority of otherwise healthy people, again, another piece of information that, hey, supports that we don't have to treat them all. But there's lingering questions. A randomized trial of primary pulmonary cocci, placebo-controlled, has never been performed, shockingly. And so the question is, if you give it, won't it speed up the illness, resolve it faster? And seems like it ought to, right? Well, we don't know the answer to that question, and hopefully someone will be able to answer that question for us somewhere. But part of the problem is a diagnostic test, because it's very hard to diagnose early on. We'll get to that someday. Okay, so diffuse coccidioidal pneumonia. Here is another case. He did have a history of myasthenia gravis. He was on prednisone and Cellcept. He lived in Hawaii, but he did get his neurological care at Mayo Clinic. So when he had two weeks of fever, cough, shortness of breath, and confusion, instead of going to the emergency locally, he flew to Arizona. And he did have one of these diffuse coccidioidal pneumonias, and he was quite old, had a RN daughter who was also driving the care. He was placed empirically on voriconazole, 4 TB meds, lots of antibiotics, antibacterial agents. And I think you could have made a case for amphotericin here. He did have respiratory failure with that x-ray, not surprisingly. He refused intubation, but we eked him through with BiPAP, and I'm still seeing him years later. And he's been on fluconazole 600 to 800 milligrams since that time. So the idea here is treat at least 12 months. Immunosuppressed patients always take longer than that. And I would get to a real long treatment duration before talking about stopping there. There is no endpoint spelled out in the IDSA treatment guidelines. It's not 12 to 24, 12 to 36, or 12 months to 5 years. It's just at least 12. And I would agree with that because some just go slow. Here we have a case of chronic cocci. She started off as a 26-year-old healthy woman in 1972, so you can imagine the type of story we're going to talk about here. She was diagnosed then with cocci. She didn't have any treatment, as would be appropriate, and her symptoms improved. She felt okay, but periodically someone would take a chest x-ray and say, whoa, there's a problem here. But she felt fine. In 1994, her cough recurred, her sputum culture was positive, her serology was positive, and she was treated with amphotericin B and felt better. But thereafter, a few years later, cough recurred, and she went on various trials of fluconazole without really any improvement. She went on a posaconazole trial, and she did improve, but after a couple years, I can't take the side effects anymore. She stopped it, went a few years, and then, or a year, and then came back. When I saw her in 2004, we put her back on itraconazole because she could tolerate it okay. Symptom control was okay, but nobody had any idea that we were trying to do something curative here. So I'm just going to run through some chest x-rays. You can see here she's got a lot of fibrosis and what looks like either bulla or upper lobe cavities. And here is her CT scan. You can see this very large cavity here, and this is not a dropped lung, that's just one really big cavity there. So she almost had no lung at all on that right side. These are very hard to treat. Almost nothing really gets you to an acceptable result, somewhat because you have so much damage already done. So your options are everything we've said, treat a really long time, try to minimize side effects and find something acceptable, or find a trial to enroll in. So real briefly, another case is 67-year-old woman, Arizona winter visitor. She had some left-sided chest pain, but incidentally in the workup, she was found to have a nodule, and she went to biopsy. And had a CT scan, I'm sure all much to Dr. Empel's horror. But she didn't have any symptoms because the original chest pain had already gone away and probably wasn't related at all. And no treatment was offered. Something similar, asymptomatic cavity, a 35-year-old man. He had a transient respiratory illness, and then that resolved. He, a couple months later, needed a routine physical examination, and a cavity was seen. So everyone gets excited, and they biopsied and did coccyserology. And again, he had this nice little cavity. He's having no symptoms, so we followed it. So IDSA treatment guidelines: asymptomatic lung nodule, asymptomatic cavity, no treatment needed, observe for stability.